The next question to team 6. Let's assume you are an intern or a resident posted in surgery ward. One of the patients in the ward is scheduled for surgery for pheochromocytoma. Now, keeping in mind the hypertensive crisis which can occur during the surgery, the professor tells you to give alpha and beta blockers to the patient preoperatively. But he forgets to tell you that which should be given first. Now, after reading from various resources, you come to conclusion that alpha blockers should be given first, followed by beta blockers. What is the funda behind this?
Adrenergic receptor stimulation by catecholamines. Sir, would you like to explain this, sir?
Yes, the answer is correct in this way. So we have to administer the alpha blockers first and then the beta blockers, because if we give the beta blockers, so then there may be itself some vasoconstriction which may precipitate the condition itself also. Okay, and sometimes we can give the both alpha plus beta blocker combined, just like the labetalol or carvedilol. Okay, so it can be given, but it's better to give the alpha blockers first.
Thank you, sir. So that comes, that ends the first round, and we'll move on to the second round. At the end of third round, we'll be updating all of your scores. So this is the second round, the integer game. Each team will be given 4 questions that demand an integer or a number as an answer. The team should add up all the numbers and give the total sum. Marks is 30 per question, and partial marks will be given if the answer is within a plus or minus range, which differs from each question. It will be mentioned in the slide. The time limit is 1 minute.
So first for team 1, I'll read out the questions. First, what is the dermatome supplying the umbilical region? Second, posse-immune type of RPGN, rapidly progressive glomerulonephritis. Third, compartments deep to extensor ligament of wrist. And fourth, HHV, human herpes virus type, resembling bacillary angioimatosis. Your time starts now. Thirty seconds left.
According to us, the answer is 26.
So the correct answer is 25. The first question was the dermatome, so it's T10, right? Then posse-immune was type 3. Next was the compartment, so there are 6 compartments, there are 6 extensor compartments for tendons of extensor muscles, and the HHV virus 6 resembles bacillary angioimatosis. So do the judges have anything to add? Okay. So we'll move forward with teams 2. The questions are: the interleukin implicated in multiple myeloma. Second, type of collagen defect in Alport syndrome. Third, the week when physiological herniation of the gut through the umbilicus occurs. Fourth, Brodmann area number of the part of the brain that is making you comprehend what I am saying right now. Your time starts now. Seconds left.
Answer is 62.
Okay. So the answer is 38. The first one is IL-6, interleukin 6. Next was Alport syndrome, so it's type for collagen defect. And it's the 6th week when the physiological herniation of the gut occurs, and it's 22 Brodmann's area.
What was the answer you gave?
Yeah, I would like to ask what was your answer again? 62. Yeah, so where did you go wrong? All right. So we'll move to team 3 now. The questions are, erythema infectiosum is which day disease? Second, in which month ossification center of calcaneum occurs? Third, CD marker of Ewing sarcoma cells. And fourth, which chromosome is affected in Prader-Willi syndrome? Your time starts now. Thirty seconds left.
26.
Any other team would like to answer? All right. So the answer is 125. I guess you went wrong with the Ewing sarcoma thing. Well, it's 5th day disease and the 6th month in utero. CD99 is the marker and the chromosome 15 is related with Prader-Willi syndrome.
What was their answer?
It was, what were your answer again?
26.
Yeah. Okay. Team 4 now. First question. Which chromosome is affected in Cry-Du-Chat syndrome? Second, Arnold's nerve is a cranial nerve. Which number? Third, in Beckwith-Weidman syndrome, which WT gene is affected? And fourth, normal body temperature, 37 degrees Celsius, is exclusively detected by which type of TRPV thermoreceptors? Time starts now.
Answer is 19.
Answer is 19. So, would you like to elaborate by each question?
First, which chromosome is affected is 5.
Chromosome 5, yeah.
Arnold nerve, cranial nerve 6.
Okay.
In Beckwith-Weidman syndrome, WT2 gene is affected.
All right.
And normal body temperature is TRPV6.
Okay. So you said Arnold nerve is 6, it's cranial nerve 10. And it's not TRPV2, it's TRPV, not 2, it's TRPV3. Yeah, so still, somehow it was 19, okay.
What was your total?
Yeah, it was 19, ma'am. 19?
19?
Yes.
Okay, so you are within range.
Yes.
Got it.
Okay. So next team 5. Questions are, first, CFTR gene is located in chromosome number. Second, cranial nerve affected in Kallmann disease. Third, taste sensation for circumvallate papillae, which is taken by which number of cranial nerve. Fourth, type of collagen defect in good pasture syndrome. Time starts now. 30 seconds left.
Answer is 30.
Sorry?
30. 30.
30. All right. So the answer is 21 plus minus 3. It is chromosome number 7 for CFTR gene and cranial nerve first olfactory nerve for Kallmann syndrome, cranial nerve 9 and type 4 collagen in Goodpasture syndrome. Coming to team 6. And your questions are: Christmas factor. Second, factor number that needs to be assessed in heparin dosing. Third, enzyme commission number of the lyase class of enzymes. And fourth, type of hypersensitivity involved in Arthur's reaction. Your time starts now.
आंसर दिख गया आंसर दिख गया तो क्या करोगे
We'll still go for their answer first and see.
if they can get the answer right, let's see.
Christmas factor 7. Factor in heparin dosing is enzyme commission of lyase is 4. Hypersensitivity is type 4.
So the total is?
$25.
Yeah, this shows the answer. Just record his answers once more for each of the points. Just get the numbers.
Yeah.
Christmas factor 7.
Okay.
Second is 10. Third, enzyme commission 4. And type of hypersensitivity 4. Type 4.
So you have answered 2 correct.
But did he get 4 right?
No, he got 2 right, ma'am. Yeah.
Right.
Yeah, first and fourth are wrong.
Correct.
Yeah.
So I think we have to deny you a fair amount of marks.
Yes.
The answer was flashed and you got 2 wrong still.
Yeah.
Right?
Yes, ma'am.
So also in your first question,
Yes, ma'am.
so can we go back?
Okay, ma'am.
Right.
Yes, ma'am.
For the answer for 4, are you completely sure it should be HHV 6
Yes,
or
ma'am.
is it should be 8? I mean, your total would be still okay, but I think it should be HHV 8. But again,
Ma'am,
maybe you've read something somewhere.
we read that, ma'am, like how much we know, we read HHV8 as associated with Kaposi sarcoma.
Kaposi sarcoma, but that is the disease that most closely resembles
Right.
bacillary angioimmunity, right?
Yes, ma'am.
HSV6 causes that slapstick.
Yes, ma'am, erythema
So
infectious.
where is the bacillary angioimmunity pattern?
Right, ma'am.
Like,
Yes, ma'am. Yes, ma'am. We can consider it as HHV8, ma'am.
but the total is still working,
Yes, ma'am.
so that's why I didn't come.
Yes.
Then.
So we'll go with HHV8 for the answer.
But it's okay, the total works.
Okay, moving to round 3.
Last one they put to me, Marjorie. I think they will do to connect people but the meeting are
So the round 3. Round 3 is connect the dots. So one picture will be there with multiple clues. Some will have 4 clues, some will have 5 clues. The clues are related in some manner. So the goal is to identify the connection and explain each clue. The connection is for 20 marks and each clue is for 5 marks. Total marks is 40 and the total duration is 1 minute. And the marks will be allotted by computer for this round. So the first question for team 1. Your time starts now.
30 seconds left.
Like we are not able to judge the diagnosis, but we think that battery and charging relates to a battery of symptoms or something like that.
Okay.
And B is coloboma, we think.
Okay.
And the rest two we are not able to make out.
All right. So the answer is charge syndrome. First is indicated by charging, the name of the syndrome. The second is coloboma, which he got right. The third is corneal atresia. And the fourth is hockey stick palmar crease, which is seen in the syndrome.
So he got almost 2 right?
Yes, ma'am. We can, if we consider the charging as, yes, ma'am, 2 right.
Something about charging, whatever, almost 2. 50% right.
Moving on to the second question. The time starts now.
Thirty seconds left. We are not sure of the diagnosis.
Okay.
Second image probably resembles a seal. First image probably resembles the classic demography, which is infants, and the third image resembles a viral infection. So maybe a viral infection in infants with a sign about seal.
All right. Any other team wants to answer this question? Mike.
Castleman syndrome.
Castleman syndrome? No. Any other team wants to give it a try? No? Okay. The answer is croup, a coughing child, barking seal like cough, parainfluenza virus, and a steeple sign, which is seen on the chest X-ray over the trachea because of subglottic narrowing. So the next question for team 3, your time starts now. Yes?
A diagnosis is Ramsey-Hunt syndrome. Justin Bieber is recently suffering from this, and it is herpes zoster oticus, which is depicted by that ear.
Okay.
Justin Bieber, Justin Bieber, herpes zoster oticus, and this is that virus, herpes. This is varicella zoster virus, herpes zoster virus in the microscopy, and the nerve affected is geniculate ganglion. Geniculate ganglion is involved. Facial nerve palsy.
And
Bell's palsy.
Yes, that is correct. It's Ramsey-Hunt syndrome. Justin Bieber was recently diagnosed with this condition. The second histopathology shows Cowdery type A bodies, which are internuclear bodies. The third picture is vesicular lesions seen on the pinna and external auditory canal. And the fourth picture depicts the involvement of facial nerve. So the fourth question for the fourth team. Your time starts now. Yes? Mic, please.
All of these present with coughing, pneumonia-like symptoms, something with lung pathology.
Okay. And what about the question? What is the blunder in clinical practice that we are referring to here?
Time's up.
Any other team wants to answer this question? No? Okay. The answer is all these organisms are known causes of culture negative endocarditis. But one of the most common causes of culture negative endocarditis is administering antibiotics before sending samples for blood culture. Would you like to add anything to this?
The first part I'm quite comfortable with, right? The second part, I have not figured out what you're trying to say actually.
Yes, ma'am. So we usually the antibiotics are administered.
Just because antibiotics are administered, it should not cause a culture negative endocarditis. Means if you are saying it causes, that sounds, you may end up with a culture negative endocarditis,
Yes,
meaning endocarditis that does not get diagnosed.
Yes,
because antibiotics were administered.
Yes, ma'am. Yes,
means
ma'am.
you could not diagnose the etiological agent because once antibiotics are administered, you will not be able to culture the organism very well.
Yes.
But antibiotics would not cause the culture.
Yes, ma'am. It's one of the
would not
blunders
cause
in clinical.
endocarditis.
Yes.
So I think maybe the phrasing needs to be better, probably. Just the phrasing making no sense. But also, I think these particular organisms, we would still culture them.
Okay.
These particular organisms, the way we need to culture them is not the routine culture in many ways. So maybe we could still culture them even if antibiotics were given. But it's okay. Technically, I understand that you're trying to make sense. So we should give. I mean, whatever your computer should give marks.
Yes. The connection that you made was all of them lead to cough-like symptoms and okay.
So the disease,
Yes.
you get the disease right?
Yes.
Brucella doesn't cause cough-like symptoms. You know, that's like an Brucella, not
Bordetella. Question 5. Your time starts now.
Thirty seconds left.
The second image depicts bullet-shaped phalanges, and the third one show dwarfism, and fourth one board legs.
Board legs. Okay. Could you give us the scientific term for it, the technical term?
Time's up.
Okay. Any other team wants to explain this completely? No? Okay, so the answer is achondroplasia. Actor Peter Dinklage was, who's an actor in Game of Thrones, he's known to suffer from this condition. The trident sign of hands is seen in the X-ray. 7 dwarfs indicate dwarfism, which is seen in achondroplasia, and rhizomelia, which is proximal shortening of the limbs, and genovarum, the term I was looking for, which indicates bowing of the legs. So would you like to add anything to this, sir?
I think this is your best question.
Thank you, ma'am. Moving on to the next question. Question 6 for team 6. Your time starts now.
Thirty seconds left. First picture depicts of malar rash and kidney depends. It's some of glomerular nephropathy and there is chain-like deposition, the key ring.
Okay.
And time's up.
You can explain. Go ahead. Okay. Any other team wants to give this a try? Give the mic.
So it is the butterfly rash or the malar rash. Then
Okay.
the Selena Gomez suffers from lupus nephritis.
Yes.
And that is also indicated by the kidney. Then that could be indicative of rheumatoid arthritis with
Rheumatoid arthritis?
Rheumatoid.
Okay.
And the next may be indicating some periosteal thickening.
What is the deformity called?
What is the deformity?
Sorry, sir, I don't know.
So what's the final diagnosis?
What is your diagnosis?
Final?
SLE. Yes, that's correct. There's another team which wants to explain. That is? Okay. So the answer is SLE, butterfly rash, which is seen. Selena Gomez, she has SLE. Lupus nephritis, it's a nephritic pathology, not a glomerular pathology. And the wire is indicating wire loop lesions. And the arthritis, Jacquard arthritis, which is deforming but not erosive. I think sir was looking for this.
In layman's terms, this deformity of Hon'ble is also called as Hitchcock's deformity, as written in some of the books.
Yes.
But I cannot see, you have shown kidney here, but I cannot see wire loop lesions here.
So the wire above it, the wire loop.
अच्छा ऊपर ठीक है अच्छा okay. So it's okay, nicely made.
Thank you.
And what are the urine findings in such cases? Typical urine findings? Urine is also called as liquid biopsy of kidney, na? So what are the typical urine findings in such cases which triggers the mind of a clinician to go for investigations to confirm lupus? It's active urinary sediments. You will get everything, like red cell cast, pus cells, crystals, everything. Active urinary sediments, that's the nomenclature.
Thank you, sir. So we come to the end of third round. We'll move on to round 4. At the end of round 5, we'll update the scores and we'll let all the teams know. Round 4. It's based on image-based questions. 1 question per team. An image will be associated with each question. 40 marks is allotted. Partial marking is allowed. And the duration is 40 seconds. Kindly note, it's not 1 minute, it's 40 seconds. So the first question for team 1. Name the arteries labeled 1 and 2 and name the test that is used to assess adequate anastomosis or collateral blood flow between them. Your time starts now.
20 seconds left. So the first is radial artery and the second one is ulna.
Okay.
And we are not sure about the test.
Okay. Any other team wants to give the answer? Yes. Rahul?
Don't know the exact test, but there is a method, palm compression.
Yes.
There's something blood flow in the dorsum of hand.
Right. There's a name for that test.
Oh, sorry, I don't know.
Okay.
I'm not recalling that name.
Anyone else wants to give the answer? Audience? Okay. So the answer is Allen's test, the test that she described. And the first artery was radial artery and the second is ulnar artery, so partial marks will be given for that. The second question. A 56-year-old man comes with a history of worsening cough and orthopnea for the past 2 years. On physical examination, he has dullness to percussion at both lung bases and diffuse crackles in the upper lung fields. Loud S2 and ejection systolic murmur were also heard on auscultation. He is afebrile and echocardiography shows marked left ventricular hypertrophy and severe aortic stenosis. The representative gross appearance of the open heart is shown in the figure. Which underlying condition best accounts for his findings? Your time starts now.
This is associated with a rheumatic heart disease in which there is a fusion of aortic cusps. Not able to recall the exact. Loud S2 and ejection systolic murmur and left ventricular hypertrophy all are consistent with aortic stenosis.
Okay. Any other team also wants to guess this? No? Okay. So the answer is bicuspid valve. The gross specimen shows a bicuspid valve which has a tendency to calcify with aging, which eventually results in stenosis. So would you like to add anything, sir?
Actually, the images was not very.
Yes.
Okay, go ahead.
Okay. Thank you, sir. Question 3 for team 3. A 35-year-old man from southeastern United States presents to the clinic with an intensely pruritic rash. He recently had been cleaning the area under the porch of a house owned by a woman who fed multiple stray cats there. He was not wearing shoes. On examination, his vital signs are normal. He has a vesicular and bullous lesions on his feet. What is the most likely causative agent?
Toxoplasma gondii.
Okay.
Since toxoplasma it resides in the cats, maybe it infected the person to that means.
Okay. Any other team wants to try this? No? Alright. So the answer is actually hookworm or Ancylostoma brasiliensis. The image showed characteristic serpiginous lesions, and the larvae of this parasite actually, the eggs are actually passed in the feces of dog as well as cat. Would you like to add anything more? Thank you. So the next question for team 4. Identify the arrow mark structure and what is the pathology?
Seconds left.
Thoracic duct, beaded epinis.
Sorry, can you repeat? Repeat your answer.
Thoracic duct.
Thoracic duct. Okay. Any other team wants to give it a try?
Because it is a region of pelvic region showing hip bone, bladder, and it is probably femoral artery showing deposition, so it may be a case of atherosclerosis.
Okay. Any other team wants to give it a try?
Okay.
No other team wants to give it a try? Okay. Any other team? Okay. Right. So the answer is actually the structure is dilated tortuous papiform plexus of veins, and the diagnosis is varicocele. Yes, ma'am. So the next question to team 5. A 45-year-old woman presents to her physician complaining of intense hip and leg pain. The pain is severe enough to limit her movement and wake her from sleep. Upon physical exam, severe hepatomegaly and splenomegaly are noted. Blood is drawn and a complete blood count is obtained, and these are the values. Please have a look at it. An MRI of the thigh was obtained along with a bone marrow biopsy, which I'll be showing in the next slide. This is the image. The question is, a mutation in which of the following genes has most likely led to this woman's symptoms?
Seconds left.
Bosses, it's option 2.
Yes.
F, F,
FGFR3. Okay, we just need 2 minutes. There's a technical delay. So we are noting down your option is option 2, FGFR3. Am I right? Okay. We'd just like to introduce ma'am has come. Garima ma'am. Morning, ma'am. Just a second, ma'am. Okay, coming back to the question, it was question 5. So the slide, there's a technical error in the slide, so it's missing. I'll be reading out the answer for this. The answer is actually Gaucher cells, and the mutation is actually seen in glucocerebrosidase, that is option 3. It leads to accumulation of sphingolipids in cells and thus organomegaly, pancytopenia, and osteonecrosis. Bone marrow biopsy showed tissue paper patterns of lipid accumulation intracellularly, as you can see here. This is consistent with type 1 Gaucher's disease, since there is limited involvement of the CNS, and the chief complaint was bone pain in an adult. Moving to the next question. Question 6 for team 6. A 58-year-old man has increasing fatigue, back pain, and his workup reveals the following. A radiograph of the spine shows multiple lytic lesions. After this patient's sudden arrhythmic death, autopsy shows that his adrenal gland contains amorphous hyaline material seen here with a Congo red stain to your left. What is being stained in the figure on your left?
Amyloid.
Yes, yes.
Amyloid.
Amyloid, could you explain a little bit more? The type of amyloid? What is the structure that is being stained? Would you like to make a diagnosis?
Serum amyloid A.
Can you repeat?
Serum amyloid A.
C-type amyloid. Okay. And what is your diagnosis? Okay. Does any other team want to try? Yeah. Mike, please.
Multiple myeloma, gamma
Okay.
light chain deposition.
Right. That's the right answer. This is a classic case of multiple myeloma, and excessive myeloma light chains form AL type amyloid that is deposited in many organs, including the adrenal gland, which was seen in the histopathology section. So we come to the end of round 4, and we have tallied all the marks till round 3, just updating them. Team 1 has 330 marks. Team 2 has 200 marks. Team 3 has 170 marks.
In last round, in round 4, the last answer was given by the team 6 or somebody else?
Somebody else, sir. Somebody else. Team 4, 120 marks. Team 5, 210 marks. And team 6, 15 marks. Okay. Team 1. So proceeding to round 5. The name of the round is Diagnose. It's in the name itself. It's a clinical case-based round, and one challenging case will be given per team. And the time limit is 1.5 minutes, that is 90 seconds. Marks allotted is 50 and passing marking is allowed. So coming to question number 1 for team 1. A 42-year-old man is evaluated for recurrent nausea and vomiting. The patient has nausea and upper abdomen discomfort after meals and feels full even after eating small amounts of food. He also has experienced several episodes of vomiting of undigested food particles but has had no fever or diarrhea. The patient has a history of type 1 diabetes mellitus and hypertension. The abdomen is soft, non-distended and non-tender with no organomegaly. Bowel sounds are normoactive and stool testing for occult blood is negative. Upper gastrointestinal endoscopy reveals no abnormalities. Treatment with an oral medication X is initiated, but it is stopped after the patient experiences abnormal involuntary movements. A macrolide antibiotic Y is now prescribed, which improves his symptoms. Diagnose the condition and name the drugs X and Y. The time starts now.
Forty-five seconds left.
You can give a guess. There's no negative marking.
We feel that it is some Helminth disease.
Okay, Helminth disease. Okay.
Okay, and antibiotic Y can be a macrolide. We are making a guess azithromycin.
Which drug?
Azithromycin.
Azithromycin. Okay. And drug X?
About the diagnosis, we think that it may be a Helminth disease. We don't know the name exactly. And for drug Y, we are saying azithromycin. And drug X, we are not clear.
Okay. Any other team wants to guess? No? Alright. The diagnosis is diabetic gastroparesis. It's an autonomic neuropathy which is commonly seen in diabetic patients, and the drug X is metoclopramide. And after administering it, the patient experienced extrapyramidal side effects, because of which erythromycin was given. And erythromycin is given in patients of gastroparesis because it activates motilin receptors. So do you have to add anything, sir?
Yes, the question is very well framed. But other effective drugs, prokinetic drugs are available, which are more effective than the erythromycin. The effect is not so prominent of erythromycin. Okay, it may be used, but other effective drugs available. Okay.
Thank you. Moving on to question 2 for team 2. A 63-year-old man has increasing irritability over 3 years. He wandered about his neighborhood, complaining to the neighbors about everything. He had no memory loss and was always able to find his way back home. The neighbors were pleased when he developed aphasia. On physical examination, there were no motor or sensory deficits and no gait disturbances or tremor. MRI of the brain showed bilateral marked temporal and frontal lobe chiral atrophy. He died of pneumonia 1 year later. On autopsy, the frontal cortex microscopically showed extensive neuronal loss and some remaining neurons showed intracytoplasmic faint eosinophilic rounded inclusions that stain immunohistochemically for tau protein. What is the most likely diagnosis? The time starts now. Forty-five seconds left.
This seems to be a case of an autoimmune disorder. The neurons of the patient are multiple sclerosis. We are taking a guess, multiple sclerosis.
Okay.
We're not certain. The eosinophilic infiltrates are also consistent with autoimmune activity. Also, the atrophy and the destruction of neurons in general could be due to autoantibodies. No sensory or no sensory or memory loss suggests that it's not Alzheimer's.
Okay.
So my guess is multiple sclerosis.
Any other team wants to take a guess? Mike.
Alzheimer's disease confirmation by tau proteins which deposit.
Okay.
Neurological symptoms are also consistent.
Right. Can you explain why your diagnosis is Alzheimer's even though the man had no memory loss?
Maybe he's on medication.
Okay. Any other team wants to take a guess? Right. The diagnosis is actually Pick's disease. Frontotemporal lobar degeneration with tau containing inclusions, and Alzheimer's can actually be ruled out because there's no memory loss. Gradual memory loss is characteristically seen in Alzheimer's. So would you like to add anything?
This is a close histomorphological resemblance with Alzheimer's, but of course it differs clinically. So this was, I must say, this was a tough question.
Yes.
But still, were they able to get it or not?
No, sir. No, sir. No. Okay. Moving on to the next question. Question 3 for team 3. A young man developed pain in his right gluteal region in the posterior aspect of the thigh and around the posterior and lateral aspects of the leg. On further questioning, he reported that the pain also radiated over the lateral part of the foot, particularly around the lateral malleolus. Over the following weeks, the patient began to develop muscular weakness, predominantly foot drop. A computed tomography scan of the abdomen and pelvis revealed a mass in the posterior aspect of the right side of the pelvis. The mass was anterior to the piriformis muscle and adjacent to the rectum. Identify the affected anatomical structure and diagnose the pathology. The time starts now.
So the answer appears to be it appears to be a tumor that is associated, which is causing which is compressing the roots of the sciatic nerve, which is causing sciatica pain that is radiating, as well as it is also causing a characteristic foot drop that is associated with motor weakness of the sciatic nerve.
Okay, and what is your diagnosis of the pathology?
Maybe a tumor associated with the anal canal or something.
That's correct. Tumor of the sciatic nerve. Ma'am, would you like to add anything to this one? No. Okay. Moving on to the next question. Question 4. A female newborn is delivered at 32 weeks of gestation, and the infant has some immediately noticeable abnormalities. The patient shows a small mandible and other facial abnormalities. Lateral cephalometric radiography shows hypoplasia of the facial bones, and occipitomental radiography shows hypoplasia or discontinuity of the zygomatic arch. Genetic testing confirms a mutation in TCOF1 gene. Which of the following is the most likely what is your diagnosis, and what is the embryological basis for the development of such features? Thirty seconds left. Ten seconds left. Mike.
We couldn't get the exact diagnosis, but something related to maxilla, pharyngeal arches defect or maxillofacial, zygomatic.
Okay. Any other team wants to give this a try?
I'm not sure about this, but maybe it is due to failure of migration of neural crest cells and leading to velocardiofacial syndrome, maybe. So the maxilla and mandible don't develop because neural crest cells form most of the bones of the skull region, and so I think.
Okay. Any other team? Okay. So the answer is Treacher-Collins syndrome. You were right about the pharyngeal arches. There is a defect in development of the first and second pharyngeal arch, and it characteristically presents at birth. It looks like this, and there is a genetic defect in the gene TCOF1 among other genes. All right. Moving to the next question. Question 5 for team 5. A 26-year-old man comes to his primary care provider's office because of hematuria, flank pain, and a palpable flank mass for the past 3 months. He has an extensive family history of cancer, and his brother has been recently diagnosed with bilateral retinal hemangioblastoma. Genetic testing confirms the diagnosis. What is your diagnosis of the overall pathology? And in this patient, which is the most likely location of the mutation? 45 seconds left. You can give it a guess.
I guess it is due to the mutation of RB gene.
RB gene, okay. And what is the overall pathology? Which disease are we talking about? The time is up. Any other team wants to guess? Yes.
Looking at the family history, I think it's Lee-Fromeni syndrome, the weight hypothesis. And I think the tumor is in kidney, suggested by the hematuria, flank pain, and palpable flank mass.
Okay.
RB gene could be defected as a part of Lee-Fromeni syndrome.
All right. Any other team wants to guess?
Lee-Fromeni is concerned with P53 gene mutation.
Okay, yes.
Can you name the mutation? Which specific mutation? Whenever you talk about RCCs, इसके साथ वाला mutation तो we always talk about it first.
Okay, so the answer is von Hippel-Lindau disease. And the mutation is seen in chromosome 3. The gene, it encodes for the protein, the VHL protein, which is involved in angiogenesis, which is the reason why it presented with hemangioblastoma. It also presents with renal cell carcinoma. So do you have anything to add, sir?
Yes, and not only this classical renal cell carcinoma, but other variants of renal carcinoma like chromophobe carcinomas and other ones, they are also have some genetic associations also. So you must also read about this them, like some of them are associated with brain tumors too. Chromophobe also has got Bird-Hogdube syndrome association. So this is at least important from your PGME interest point of view, all these things.
So do you have anything to add? Thank you, sir. So that ends round 5. Just 2 minutes, the slide is missing.
Get answered by the team it was directed to? Or
No, ma'am.
It was an open answer, right?
It was an open answer. Just tell them to wait 2 minutes.
Please just wait for 2 minutes.
Question 6 for team 6. You are in the emergency department when a 67-year-old woman is admitted with acute nausea, vomiting and flank pain. She has a history of atrial fibrillation but has not been compliant with her oral anti-medications. She is hypertensive and the values are 220 by 140 and labs reveal an extreme elevation in lactic acid levels, lactic acid dehydrogenase levels and moderate leukocytosis. With a clinical suspicion and as well as a diagnosis, you order a CT angiogram which is shown in the figure to your right. What is the diagnosis? Your time starts now.
Forty-five seconds left. Time's up.
Time is up. Any other team wants to guess this?
By seeing the CT angiogram, we can guess that in the left renal artery there is an occlusion. So we guess it's a diagnosis of renal artery stenosis. And since the kidney is getting less blood supply, so there is elevation in LDH because of ischemic conditions and there is tissue damage. Then hypertension is due to the increased release of renin from the kidney due to SNS activation. And the reason of flank pain is again the kidney pathology, and atrial fibrillation is because of hypertension.
Yes, that is the correct answer. It is thrombotic renal infarction. So do you want to add anything to this?
LDH is very high.
Yes, sir. So that ends this round. Moving to the next round, round 6. Round 6 is called Who Am I? So one riddle will be provided per team and the time limit is 30 seconds and 30 marks will be provided per question. Question 1 for team 1. I am very small, but still I could be very dangerous. I love to live in hospital environments where I usually rest on ventilators, catheters and burn patients. I could be very dangerous for those who are very weak people and who can't fight me. I can cause septicemia in them, which characteristically manifests with the dermatological lesion in the figure on your left. People can't really escape from me, but I can't live without oxygen. Who am I? Your time starts now.
We think that it is Pseudomonas infection.
Okay.
Pseudomonas aeruginosa may be the cause.
That's the correct answer. The answer is Pseudomonas aeruginosa. Ma'am, do you have anything to add to this one? So the lesion that you saw was ecthyma gangrenosum, and it is a strict aerobe. Yes, and also it is a member of escape organisms, which shows multi-drug resistance. Coming to question 2, I am a fastidious facultative intracellular organism. I divide at a slower pace. I stain pink on gram staining. I have the ability to invade mammalian cells and RBCs. I am transmitted to humans by cat scratch or cat bite. I cause epitrochlear lymphadenopathy and erythematous papule or pustules in humans. I can also cause hepatitis, splenitis, and retinitis at times. Who am I and what disease I cause?
Fifteen seconds left.
From cat, we can think of toxoplasma infection.
Okay.
But I don't think it's toxoplasma because it causes CNS manifestations. So I'm not certain.
Okay. Any other team wants to answer?
Hensley, cat scratch disease, or bacillary angiomatosis, or hepatic fever.
Yes, that's the right answer. Do you want to add anything to this one? Moving on to question 3. I grow when you smoke. I like your ileum and stab it with a dagger. Some say I look like a string. Some say I look like a snake. And some say I have a feel of rubber. But your body recognizes me as a yeast. What disease am I? Ten seconds left.
Maybe it is a disease caused by a fungal pathogen that shows multiple forms like hyphae, pseudo-hyphae, and yeast forms.
Okay. Any other team wants to give it a try? Yes.
It's Crohn's disease, and ASC antibodies are found.
Right. That's the right answer. Smoking is a risk factor, and stabbing is actually deep knife or serpiginous ulcers, and the feeling of rubber is thick rubbery intestinal wall. And yes, ASC antibodies are formed in the body, which is recognized for yeast. So, do you want to add anything, sir?
No, it's so good.
Moving on to next question. Before birth, I am a bridge between the mighty arch above and a highway below. These roads split to take us to a destination of the deflated balloons. But as the balloons get inflated, I give up my life, but leave behind a tombstone. Sometimes I choose to remain immortal. That is when I enjoy mixing the blue and the red. Who am I? Your time starts now. Right. That's the right answer. The mighty arch was the arch of aorta. The highway was the pulmonary trunk. Move on to the next question, question 5. I will be the drug you will be looking for when you will be suffering from HIV with pneumonia and your CD4 count is less than 200 per microliter. Who am I?
Fifteen seconds left. Time's up.
Your time is up. Any other team wants to give this a guess? Yes? The drug. Your diagnosis is correct. The answer is cotrimoxazole, which is the drug of choice in pneumocystis pneumonia. Moving on to the next question. Sir, do you want to add anything, sir? Moving on to the next question, question 6 for team 6. I last for 100 days and I need air to survive. I increase camp in your cells. I have 3 stages and you can only get rid of me if I am treated in the first stage of infection. People who have me vomit as soon as they cough. Who am I? Your time starts now.
Fifteen seconds left.
Streptococcus pneumoniae.
Okay. Any other team wants to give it a guess?
Bordetella pertussis.
Right.
100-day cough.
Could you explain? Okay, right. The answer is Bordetella pertussis, also known as the 100-day cough in China, and it can only be gotten rid of in the first stage of infection, the catarrhal stage, where there is low fever and coryza. Somebody want to add anything? So we come to the end of round 6. We'll move on to round 7. Morning, sir. We'll move on to round 7, video-based questions. A short video will be played, 1 for each team, and there are 50 marks per video. Partial marking is allowed by the judges, and the duration for you to answer is 40 seconds after the video is played. Moving on to question 1 for team 1. What is the name of this sign? Your time starts now. We can replay the video if you want.
Twenty seconds left. Time's up.
Time is up. Any team wants to guess?
We are not sure, but we are guessing off-foot Trendelenburg sign.
Okay. Any other team? Alright. The answer is tripod sign. It is characteristically seen when Haemophilus influenza infection occurs. And it is also seen whenever there are signs of meningeal irritation. Moving on to the next question, question 2. Your time starts now. There are options for this question. The site of lesion in the brain in the above condition is
Twenty seconds left.
Globus pallidus.
right. The answer is globus pallidus, and the movement disorder that was seen in the video is athetosis. Moving on to question 3. Identify the appearance on upper GI endoscopy that you will see in this video. This is most commonly seen in which disease?
Seconds left.
It looks like a gastroesophageal reflux, as bubbling can be seen of the gas. And the white appearance, it could be indicated of esophageal candidiasis.
Okay. Okay. Any other team wants to try it?
From the video, it suggests, it seems that the lower esophageal sphincter is not quite opening, and the peristalsis also seems impaired. So I'm thinking achalasia maybe.
Okay. Any other team wants to try it?
Maybe Barrett's esophagus.
Okay. So the actual answer is feline esophagus, and it is most commonly associated with GERD. It is a pathological finding in the esophagogram, and it's seen during, it's a transient finding during reflux. So do you want to add anything to this? Moving on to question 4 for team 4. What organism are you seeing here, and what is its characteristic type of motility? Your time starts now.
Not sure, but tumbling motility seen in listeria cytoplasm.
Okay. Any other guesses?
I think darting leaf motility in Vibrio cholera.
Okay. Any other guesses?
Proteus.
Proteus. And motility?
Starting. Fruity is starting.
Okay. Any other guess?
Falling leaf motility.
And the organism?
Sorry, I don't remember.
The answer is falling leaf motility, and the answer is Giardia lamblia. You want to add anything more?
It was actually very characteristic. I was wondering where he got the video from.
Moving on to question 5 for team 5. What test are you seeing here, and which muscle is being tested? The time starts now.
Seconds left.
Pectoralis major.
And what is the test?
Load test.
Okay. Any other team wants to give it a guess? Okay. The answer is empty can test. It's a clinical test that is used to test the integrity of supraspinatus tendon. Do you want to add anything to this? Moving on to question 6 for team 6. Which sign are you seeing in this video, and in which condition is this characteristically seen in? Your time starts now.
Seconds left. Time's up.
Time is up.
Gover's sign seen in Duchenne muscular dystrophy.
Yes, that's right. We come to the end of round 7. So we'll be proceeding with round 8, and then we'll announce the results directly. Okay, we will be just updating the scores of all the teams before the final round. Team 1 stands at 545 points. Team 2 has 220 points. Team 3 has 360 points. Team 4 has 150 points. Team 5 has 210 points. And Team 6 has 15 points. So we'll move ahead to round 8, that is the rapid fire round. Please listen carefully. 7 questions will be asked in quick succession. Each question will be displayed for 7 seconds only, and the subsequent question will appear after the answer. The answers are one-worded and should be answered within 7 seconds or 10 seconds. 10 marks will be given for correct answer, and 5 marks will be deducted for the wrong answer. Team 1, please check your mic once. Yes. We'll start. answer according to the question. It's not just true or false. Okay.
Streptococcus pneumoniae.
False. That comes, what's the time? You got one question correct and one question wrong, so total 5 marks be given. Moving on to team 2. Check the mic, please.
L3.
albicans, candida. False. False. Downward, inward.
Yes.
Pass.
Okay. You got 3 questions correct and 1 question wrong. That adds up to 25 marks. Moving on to team 3. Please check your mic.
True.
Danish 1331 string.
Radial nerve.
Yes. You got 1 correct and 2 wrong questions, so you got 0 marks. Moving on to team 4. Please check your mic. Check your mic.
Hello.
Yes.
What do they say? False. True.
Ball and soccer.
You got 2 correct and 2 wrong, so that's 10 marks. Team 5, please take your mic. Start.
Kesar Fisher. Both. Point.
That's it. You got 3 questions right and no questions wrong. 30 marks. Moving on to team 6, please take your mic.
Hello.
So no negative, no positive, 0 marks. So that comes to the end of the quiz, and we'll be, yes? Okay. Okay, sure. Just tell the name of the strain, we'll confirm it. Ma'am, could you?
The question didn't ask strain. The question asked for species. We'll go back to the question. Is your question?
Yes. Which species?
The strain, you first give the species and then you can give the strain number. The question asked me, I have no problem with your getting marks, but the point is the question is like.
Species was asked.
Okay, we'll forgive him negative.
Negative mark, okay. Fine. Negative mark. You'll get 5 marks then. Okay. So that leads to the end of our quiz, and the results will be declared shortly. We are tallying the results. Meanwhile, sir and ma'am, if you have a few words to say regarding the event.
Okay, this quiz was made very interesting, and certainly there are few questions, they are very high level. So I would like to congratulate the organizers and who has managed this quiz very well and well managed. Thank you.
Thank you.
And good wishes to all of you.
Thank you.
I hope all of you enjoyed this very much. It seems quite interesting to me also, but it may be reduced to rounds only 5 to 6. At last, it seems somewhat lengthy.
Yes.
It may be okay.
Thank you.
Otherwise, seems very good.
Thank you.
I was just wondering that what this intense academic event is doing amidst this times of fun and frolic. So this is a shock for me. But still, I must congratulate you for organizing such an event. And it was really the quiz was towards tougher side, I must say.
Yes, sir.
I must say that only 25% of the questions were such that could be answered by a normal medico, an average medico, but most of the questions were towards higher side to be answered by intellectuals. Anyway, good efforts.
Thank you, sir.
Thank you, organizers, first of all, for inviting me, because I really had the most brilliant time today. And have you all watched a serial called House? You know, I felt I was sitting through several episodes of that serial. For those who have not, House, Dr. House. The serial is called Dr. House. And especially for you quizzers, I will say, please watch it. You know, there is this doctor, he's called Dr. House, who in each episode, he's a brilliant diagnostician. So all those cases whom no one can solve, you know, there's no diagnosis achieved. So one such case is shown in every episode, and Dr. House with his team comes up with the strangest investigations and puts together this most brilliant diagnosis. So I kept feeling through your quiz that we were sitting in episodes of Dr. House. Thank you for letting me have a very wonderful morning. Great efforts to all of you. I hope you all go on to become brilliant diagnosticians like Dr. House. My wish for you. If you continue like this, I'm sure you'll get there very, very soon. You're already there. You'll get really there, you know, making it real. Yeah. Thank you very much, Vinay and the entire team. Shiva, Rahul, Fiza, Irjanand, Utkarsh and Devesh, you put together a very brilliant assortment of questions. And I'm sure if you make this quiz public, it'll really be pretty famous quiz.
Yes.
Thank you all for it.
Thank you. The results are being tallied, ma'am. We just need 5 minutes, ma'am.
Can I ask you all how you prepared for this quiz? Or is it like there could be no possible way to prepare for it? It's just that how you are studying regularly. Did you put in some effort to prepare for this quiz? Or was it that's how you always are? Yeah? So is this something that you're always doing, or is it that you prepared for this quiz? Yeah? You're always.
Yes, ma'am. So we founded a quizzing society where we conduct quiz for juniors. 10 quizzes we have already conducted.
So I think we should really give wings to the society, and so that, you know, it helps you think and grow, and we should come out with something to work on this, and how we can make it more formal so that we have more than
these
people, and we have more audience by next year.
Yes.
And maybe more participants, because definitely putting X and Y together and coming up with Z is the biggest thing we do in medicine, right? So quizzing is definitely a part of that.
Yes. Thank you, ma'am.
All these 15s are from KGMU?
Sir, 5 teams are from KGMU, 1 team is from Prayagraj, MLNC.
I believe they actually had teams from other places. Would you like?
Yes, sir, actually. Yes, sir, so we conducted a screening round. This was around 10 days back, where 20 plus teams from all across India participated. And some teams which were selected in top 6 were from South, Bangalore and Mumbai. They couldn't make it here, sir, because of the expenses. So those who could make it here, we called the subsequent top 6.
Then you can actually think, because obviously money will be a problem, travel will be a problem always, money and time both. So maybe you can look at ways to make it online, and so you get more participation and more challenges, and you have more members who can join the team to make the questions even better and tougher, right?
Yes.
So see how you can figure out whether
Yes,
you
ma'am,
can
we are
do
trying
this
our best,
as
ma'am.
more of a national event. So in your first round, how did the students respond?
Yes, ma'am.
What was their response to the level of the quiz?
Ma'am, we had
Feedback. What
yes,
was the
ma'am. We got very positive feedback from almost 4-5 teams across India. They personally messaged me saying the questions were really good. They enjoyed the quiz.
Okay. Congratulations.
So our next event is in the 95% confidence, which will be the research presentation competition. So we want to welcome our respected judges. First of all, Professor Chaurasia sir from the Department of Cardiology. Welcome, sir. Next we have Dr. Ajay Kumar Pal sir from the Department of General Surgery. Dr. Sujit Kumar Kar sir from the Department of Psychiatry. And Dr. Harshvardhan sir from the Department of Plastic and Reconstructive Surgery.
After I announce, I'd like the team to come on stage. And I'd like to request the judges to give them the prizes. Team 3. Team 2. After that? Team 3, third place goes to Team 2, that is Triology of Phallet. Second place goes to Team 3 Eggheads. And the first place goes to Team 1 Trojan Horse. We would also like to felicitate the judges with one memento. Vimala Ma from Microbiology Department. Atin Sir from Pathology Department. Wahid Ali Sir from Pathology Department. Rahul Sir from Pharmacology Department. We're extremely thankful to all our judges for giving time for this quiz.
Winners, please come.
Shriya Datta from AIMS Patna. Please come and occupy the first seat. Shreya Verma. Gunjan Parashar. Shubham Tripathi, boss. All the participants will be getting 6 minutes of presentation followed by 2 minutes of question and answer from our panel of judges.
Good afternoon, everyone. I'm Shreya Datta from AIMS Patna. I'll be presenting my STS research paper titled Study of Olfactory Dysfunction as a Possible Early Predictor of Essential Hypertension in Middle-Aged Adult Population. So hypertension is one of the most commonest diseases globally, with around 46% of the cases being undiagnosed and majority of them being cases of essential hypertension without any clearly defined etiology. As we've all seen during the challenging COVID times, the need for a preliminary clinical indicator for the diagnosis of COVID had become imperative, and olfactory dysfunction, being one of the most commonest symptoms, had served the purpose. Studies have indicated that olfactory receptors are not only present in the nose, but also in the kidneys, which are associated with the renin-angiotensin-aldosterone system, responsible for regulation of the blood pressure. The purpose of this study is to find out whether olfactory dysfunction could serve as a possible early predictor in diagnosis of essential hypertension, making it more efficient and delaying its complications. The objectives of the study is twofold. Primarily, this is to assess the association of olfactory function with blood pressure levels in patients of essential hypertension, and secondly, it is to assess whether there is any sex-specific differences in this association. This is how the research was carried out. It was carried out in the medicine OPD of AIMS Patna, whereby the study participants were divided into test group and control group, in which there was a middle-aged population of 30 to 50 years, each consisting of 30 participants, and they were selected on the basis of inclusion and exclusion criteria. The inclusion criteria for our test group was that their blood pressure should be greater than 140 by 90 mmHg, and for the control group, their systolic blood pressure should be between 90 to 130, and diastolic blood pressure should be between 60 to 80 mmHg. The exclusion criteria was defined as those individuals who had suffered from any previous rhinological, neurological, or any other known causes of secondary hypertension. Once these groups were decided, their vitals such as blood pressure was measured and olfactory tests were carried out. There are two olfactory tests carried out, odor threshold test and odor identification test. In odor threshold test, we used the chemical 1-butanol, which was successively diluted by a factor of 2, and the patients were asked to smell them. So the lowest concentration which they could identify was called as the threshold limit. The second test was odor identification test, in which we used Indian smell identification test, whereby a sense of 10 commonly used odors were used, and they were asked to identify it correctly, and they were awarded 1 point each. Based on this, The combined odor threshold identification score was calculated, and statistical analysis was done using Microsoft Excel and Jamovi software. The results showed that the mean olfactory score for the test group was found to be significantly different from that of the control group when independent sample t-tests were performed. Analysis also revealed that there is significant negative correlation between systolic, diastolic, mean arterial and pulse pressure with combined odor threshold identification score. As you can see in the table, the systolic blood pressure is more negatively correlated with the combined odor threshold identification score as compared to the others. This shows a negative slope association between the two. The first graph shows that in our first test, odor threshold test, at higher concentrations, there was not much significant difference between the test and control group based on the frequency of identification. But in the, say suppose lower concentrations like 1:16, the percentage of people identifying the odors correctly was more in the control group as compared to test group. In the second test, the graph shows that those 10 items also had different rates of being recognized, with more percentage of people recognizing those odors in the control group as compared to test group. Significant linear regression showed that there is 10% variability in the olfactory function due to hypertension. However, no significant differences was found between male and female in the olfactory function. Various mechanisms have been indicated here. A primary one could be the presence of short-chain fatty acids, which is produced by the gut microbiota, that is responsible for activating the renal olfactory receptors, specifically OLFR78, associating it with increasing the blood pressure through the RAS mechanism, and also probably causing vasoconstriction, responsible for diminished olfaction. A second association could be the presence of common olfactory receptors in the nose and kidney, which is responsible for not only regulating the blood pressure, but also for participating in olfaction through the AC3 engulf receptors. In conclusion, the study indicates that there is an association between the olfactory function and hypertension through the RAS mechanism. And also there have been very few studies which have been carried out to assess this association. For example, a Kailwan-based study assessed that altered taste and smell perception was associated with systolic blood pressure and mean arterial blood pressure. But the disadvantage was that they considered cases which self-reported their olfactory function. In conclusion, we can say that with further research in this association, olfactory dysfunction could possibly serve as an early predictor in making the diagnosis of essential hypertension more effective. Thank you.
So it's a thought-provoking study, but there are a few concerns. You took a sample size of just 30. So could you apply it can be only hypothesis generating study at the sample size of 30, because at least you need for more than 50 in one group to prove anything significant. One thing is that. Second is that what was the COVID status of the patient, what was the COVID antibody status, what the COVID has led to in both the groups. So you did the RT-PCR in both the groups or not?
So for the COVID, we put our exclusion criteria as that they should not be suffered from COVID-19 since past 6 months. We did not do any specific test for it. We just asked the patient whether they have been vaccinated twice and whether they have suffered or not.
And third thing is that there was a linear correlation of 10%, you are saying, there was a 10%. So these olfactory scores are subjective and it has no hard endpoint, because you cannot quantify it, because there would be a subjective variability in the patient reporting once you are using any scores. So whenever the clinical scores are used, the objectivity of that test may not hold true for all the patients. And while predicting the onset of hypertension, it would be better to do a blood pressure screening rather than going for the cumbersome olfactory scores. But of course, it's thought-provoking many times. If the patient comes to you with some olfactory problem, then you should consider taking blood pressure, rather considering it as a predictor of this.
So for the first, the sample size, so it's an STS project, so we were given like less time for that. So that's why we took it as 30 in case and 30 in control. But obviously, like further studies we have to do to assess this association. And the predictor, so actually in the beginning, we had classified these individuals as hypertensive and non-hypertensive, and then the scoring system we used was Indian smell identification test and the odor threshold test, which has been used in other researches as well. So, obviously, further studies can be carried out to assess this.
Your cases had hypertension for how many months or how much long they had this hypertension?
So we try to take the newly diagnosed hypertensive cases, like for instance, 15 days back or 1 week back, they've been just diagnosed to have hypertension and they do not have any other causes pertaining to that, so that we can exclude secondary hypertension from it.
Okay. This was taken out of consideration. Any other comorbidities?
Yes, so we've taken as our exclusion criteria that.
Shreya, this is an interesting concept. I must congratulate you for that. Do you have any limitations of your study?
Could you repeat the question?
Do you have any limitations of your study?
Implications.
If you want to do it again, if you get a chance to do it again, how will you improve this study?
So we like to increase the sample size so that the association can be more clearly ascertained. And also we would like to include another aspect, like whether they've taken drugs or not, like hypertensives have taken drugs and not taken drugs. It's something which we would like to carry out to assess another association with it. And also male, female, we would like to do it again.
Hi. Very interesting
Thank you,
sir. So who did the outcome assessment? Was it done by you yourself or was it done by somebody else?
So the statistics?
No, the outcome assessment.
Outcome assessment. Sir, actually I did it under my mentor, physiology department and medicine department. So yes.
So what I mean to ask was it blinded or not?
The patients, they were not knowing about it, but we knew that the patient, this is hypertensive, this is non-hypertensive. Thank you.
So next participant is Gunjan Parashar, third year MBBS student, King George Medical University, Lucknow.
Good morning, everyone. Good morning to our esteemed judge panel. I'm Gunjan Parashar. I am presenting the topic Psychological Analysis, Clinical Examination and Evaluation of Various Treatment Options in Patients with Mastalgia at a Tertiary Care Center in India. Okay, this study was conducted under General Surgery Department in KGMU. As you know, mastalgia, that is breast pain, the most common age group that is affected by mastalgia is 30 to 50 years. The prevalence is very high, 41 to 79% according to the studies. It may be mammary or extramammary. Extramammary includes chest wall pain and non-chest wall pain. So the objective of our study was to assess the psychological status of women presenting with mastalgia and the effectiveness of the treatments available. The treatments available for mastalgia include topical NSAIDs, evening primrose oil, vitamin E, tamoxifen, danazol or meloxicam. The study was conducted under General Surgery Department in KGMU between February 21 to November 21. The inclusion criteria was all females presenting to the OPD with breast pain or chest wall pain or both. The exclusion criteria was any pregnant female, history of any drug allergy, or the patients who were lost to follow-up. Also, any female who was diagnosed with other diseases like fibroadenoma or breast cancer were also excluded from the study. We did two examinations. For the psychological assessment, we used the DAS-42 scale, and for clinical examination, we did the whole breast examination. For pain assessment, we used the VAS score and the rollover test. For management, we again used, we divided the patients into different categories. The patients were divided into two categories first. The patient who had a VAS score less than 4 were given reassurance and The patients who had VAS score more than 4 were again divided into 3 categories. Those who had only chest wall pain were given cholecalciferol 60,000 units for a week and then followed up. The patients who had both breast pain and chest wall pain were given cholecalciferol 60,000 units for a week and topical NSAIDs. And those who had only breast pain, we gave topical NSAIDs, or we divided it into 2 groups, topical NSAIDs or EPO or vitamin E. The results were, as we took 106 sample size, the p-values and the r values that corresponded to the DAS scores and the VAS scores came out, showed that the null hypothesis is true. There is no relation between the DAS score and the VAS score. No significant correlation between the psychological status and pain score or duration was found. Patients who recovered using initial treatment had average DAS score lesser than those recovering using higher lines of treatment. Both topical NSAIDs and EPO and vitamin E were found effective as found in our research. Thank you.
Congratulations for your research. And I want to know that whether any guidelines were followed for prescribing this management. Are you aware of it?
Yes, sir.
Okay. And in the end, it was the correlation was not found between the duration of pain and this psychological scores.
Again, interesting study, but I want to say that why you limited your sample size to 106? How you estimated the sample size?
So we could take more.
It is an ongoing study, or you completed the study?
So actually, this study was not mine. It was of a final year student, and.
Okay. Second thing. In the exclusion criteria, you mentioned that those who are lost to follow, they are excluded from the study.
Yes, sir.
And it's not a prospective study, it's a cross-sectional study.
Yes, sir.
So there is no point of lost to follow because you are doing a one-point assessment. अगर आप उसको फॉलो करके देखते और फॉलो अप में नहीं आया तो आपने ड्रॉप आउट कर दिया तो वो समझ में आ रही है. But lost to follow यहाँ पे कैसे relevant है? I'm not able to understand.
So actually, we only took the patients who said that their treatment is successful as in our sample size.
So that's all right. But exclusion criteria में आपने लिखा है lost to follow up. Suppose somebody is lost to follow up, you will not be able to assess that patient because that patient is not coming. A cross-sectional study में आप उनको देख ही नहीं पा रहे हो तो फिर वो criteria में आया ही नहीं. Exclusion is applicable for those patients that you are screening, applying the selection criteria, and they are not meeting the selection criteria, you are excluding them. But somebody who is not coming at all, how that person will be screened, how that person will be excluded? तो ये समझ में प्रोस्पेक्टिव स्टडीज में तो समझ में आ रही है कि आपने इनिशियल असेसमेंट किया, फॉलो अप में वो पेशेंट आया ही नहीं, तो सेकंड असेसमेंट नहीं हो पाया, तो एक्सक्लूड हो गया. लेकिन क्रॉस सेक्शनल स्टडी में लॉस टू फॉलो अप इज नॉट स्टैंडिंग वैलिड. आपने क्या सबडोमेन स्कोर्स को एनालिसिस किया? डैश 42 का, इसमें 3 सबडोमेन स्कोर्स हैं, उसको एनालिसिस किया है कुछ?
Yes, sir.
उसमें कुछ इसमें किसी में भी आपको फाइंडिंग नहीं मिली?
नहीं.
टोटल स्कोर्स के साथ भी आपको नहीं मिली?
Gunjan, right?
Yes, sir.
Gunjan. So, good, well done, good, well presented, and it is good at your level to come and present in such forums. Okay. Perhaps you would have been a bit more aware of the research had it been your own research. But good, well presented. When you talk about objectives, okay, so your objectives need to be very specific. In your objectives, you had mentioned, can you go back to your objectives slide? So yeah, so to assess the psychological status of women presenting with mastalgia. Okay. Then to determine the effectiveness of different treatment options available for treatment of mastalgia. And now you give so many options. So when you give objectives, you're supposed to be very specific and your results should match your objectives. So how do you exactly do that? That should come out in your results. So that has to be specific. That is one point. There are other things also. But good, well done, okay, and all the best.
Thank you, sir.
Our next participant is Shubham Tripathi Boss, finally MBBS student from King George's Medical University, Lucknow.
Myself Shubham Tripathi from MBBS 2018 batch. I am here to present my research article on the topic Evaluation of Growth Parameters and Treatment Compliance among Transfusion-Dependent Thalassemia Major Patients. Thalassemia, it is an autosomal recessive inherited blood disorder that results in a defective globin chain synthesis resulting in anemia. According to previous studies, majority of cases of thalassemia are reported from the Asian subcontinent. Regular blood transfusion and the iron chelation therapy, they form the basis of treatment of thalassemia major patient. Regular blood transfusion is very essential to maintain the adequate pre-transfusion hemoglobin. Henceforth in the presentation, I will be mentioning PTH for the pre-transfusion hemoglobin. So this regular blood transfusion is essential to maintain adequate PTH, which in turn results in the optimal growth and development of the child. However, the major disadvantage of the regular blood transfusion is iron overload, which may further lead to endocrine dysfunction and growth impairment of child. Previous studies have also showed that there are various factors like the serum ferritin, family income, age, etc. responsible for growth retardation in these children. And also bringing the child for frequent blood transfusion and iron chelation therapy can be a tedious task for their parents, which may lead to non-compliance. So ensuring compliance in this patient is very difficult, but if we manage to do so, it is a very effective way to minimize the growth retardation in thalassemic children. Objectives of my study are to evaluate the growth parameters in transfusion-dependent thalassemia major patient on iron chelation therapy. Then we correlate the growth parameters with the mean PTH and the mean serum ferritin levels. We will assess the compliance by categorizing the subjects into various groups on the basis of average PTH and average serum ferritin. And also, we try to establish a correlation between the treatment compliance and height velocity and the weight gain. And we try to find some factors that affect the compliance. My research was a prospective observational study. Inclusion criteria is all the patients that were enrolled in the thalassemia unit of the pediatric department of the KGMU between the age of 2 to 18 years were included in this study. Exclusion criteria: children who were less than 2 years of age or greater than 18 years of age. Children who were not started on the iron chelation therapy, and parents who were not giving consent, and children with some other systemic diseases like CKD, which may result in the growth impairment, were also excluded from this study. Sample size after applying the statistics was found to be 140, and ethical approval was obtained before starting the study from the Institutional Ethics Committee. These are both flow charts. Sir, actually, these are they are not shown here. This methodology. Sir, we first of all took the consent of the parents, and then we collected the demographic data of the patient. Then for the 6 months, we followed the patient on each transfusion session. Before the session, we carried out the clinical examination. And the anthropometric examination. The pre-transfusion hemoglobin and the serum ferritin levels were noted before each transfusion session. And we used the Z square growth charts for comparing the participants' growth parameters. We divided them into two groups, one with the pre-transfusion hemoglobin less than 8 gram per deciliter, one with more than 8 gram per deciliter, and we compared the growth parameters in both of them. And to assess the compliance, we used average serum ferritin and average PTH on the 6th occasion, and we divided the patient into 3 compliance groups, one with the good compliance, moderate compliance, and the poor compliance. I will be discussing that. And then we also tried to find out some factors that lead to the poor compliance. This is the compliance score. We use the average PTH and the average serum ferritin, and we gave score and divided into 3. The poor compliance, moderate compliance, and the good compliance patient. These are my results. In my study, 140 patients between the age of 2 to 18 years were enrolled. 60% of total subjects were male. The average age of diagnosis of beta thalassemia was 11 plus minus 2 months. The age at first blood transfusion was 8 plus minus 2 months. An average frequency of blood transfusion among patients was every 28 plus minus 6 days. An average pre-transfusion hemoglobin of the study was 8.34 gram per deciliter, and average serum ferritin was 2350 nanogram per ml. So we divided the patient into two groups, the one with the PTH of less than 8 and one with the PTH of more than 8. Then we compared the growth parameters, but as there were two groups, we used the student t-test and the Mann-Whitney test, and we calculated the mean and the standard deviation. We found that there was a significant difference in the weight for age Z score between the two groups, and also there was a significant difference between the height for age Z score between the two groups. Then we calculated the compliance score, and it ranged from 4 to 13 in our group. There was a maximum of 15. Mean compliance score was 9.3, and we found that in our study, 63% were in the average compliance category, 33% were good compliant, and 4 were poorly compliant to the treatment. This is the table. We used the Pearson coefficient R value to find a correlation between the height velocity, weight gain, and the compliance score. We found a moderately positive correlation between the height velocity and the compliance score, and a moderately positive correlation between the weight gain and the compliance score. That is, more was the compliance score, better was the growth velocity, and better was the weight gain. As there were 3 compliant groups, we used the ANOVA test to compare whether the differences between the group was significant or not. Height velocity was better in the compliant category than the other groups, and weight gain was also better in the compliant category. Then we also tried to find out some factors, and we found there was a positive correlation between the socioeconomic class and compliance score. Means lower the socioeconomic class, poor was the compliance of patient. Also there was a relation between the distance from transfusion center and the compliance score. More was the distance from transfusion center, poor was the patient compliant to the treatment. My conclusions are, growth and development of children with thalassemia major patient is significantly affected. Patient with inadequate pre-transfusion hemoglobin had more evidence of growth impairment than the others. So we should motivate the parents so that they could get the child regularly transfused. Also, as it can lead to iron overload, so we need to assess the serum ferritin from time to time so as to avoid the growth retardation due to iron overload. And we found that patients who were compliant to the treatment had adequate height velocity and weight gain than the ones who were not compliant. From this study, we used a scoring system, but it was not extensively validated, but it has been used in previous studies. So we need a properly objective validated score for calculating the compliance, so that we can motivate the parents so that they can bring their child to get regularly transfused. And we also highlighted certain factors like socio-economic class and distance from transfusion center as the factors that leads to poor compliance. These are my references. Thank you.
It's a well conducted and nicely presented study. So, and it incorporates the various issues of our country in the management of thalassemia. You talked about the socio-economic status, compliance, and these are the real issues that we have highlighted. So what is the message or impact what you think your study can lead to in the management of thalassemia?
Sir, because it is very hard to maintain compliance among patients, so by giving compliance score, we can motivate the parents. If they are in one transfusion session, they are in poor compliance, we can tell them to move into the good compliance or average compliance, so that the growth retardation among children will be minimized.
Oh, nice.
So your study is quite relevant study for the scenario for a country like India. Just want to confirm, you told that you applied t-test and Mann-Whitney U-test.
Sorry, sir?
You applied for the statistical analysis, you applied t-test and Mann-Whitney U-test.
Yes.
T-test is a parametric test and Mann-Whitney U-test is a non-parametric test. So I'm wondering whether your data is parametric or non-parametric.
Sir, student t-test for that particular data, not Mann-Whitney test.
आपने प्रेजेंटेशन में Mann-Whitney U-test भी कहा है.
For other.
कोई ऐसा था कि आपके डाटा नॉन पैरामेट्रिक था जिसमें आपने Mann-Whitney U-test लगाया था?
सर पैरामेट्रिक पे स्टूडेंट t-test. सोशियो इकोनॉमिक क्लास उसके लिए यूज किया.
अच्छा. ओके.
Shubham.
Yes.
Good. Very relevant study. Can you go back to your objectives with me?
Methodology?
Objectives, yeah.
Yes.
So, can you just give answers for each of these?
Yes, sir. Sir, growth parameters, they were found to be reduced in the thalassaemic patients, and also the one with the mean PTH of less than 8 were having poor growth as compared to the one with having more than 8 gram per deciliter. And we also divided them into compliance, and we found that majority of patients were having averagely compliant, and we also tried to find correlation between the treatment compliance. So there was that is, more the compliant the patient was, more was the height, velocity and the weight gain. And in factors we identified like socio-economic class and the distance from transfusion centers.
Suman, a small suggestion. Some of your slides are overcrowded. There are a lot of content in the slides. So when you are making presentation, just be aware that at least whoever is reading that slide, that is visible to all of them.
Sir,
like your introduction first slide, it is so much content is there. So this is just a, you can divide that content into 2 slides or 3 slides so that everybody can refer to that. Thank you.
Nicely done actually. Who helped you with the study? Did you receive some help for your study? Do you have a second?
My mentor was Nishant sir from PDA department.
You have, okay. I only had a suggestion that if you could have separated your objectives into a primary objective or a couple of primary objectives and the rest you had just kept it as secondary objectives, you could have reduced your overcrowding actually and focused on the key takeaways. That's just a suggestion, but well done.
Thank you.
So our last finalist is Shreya Verma, third year MBBS student, King George's Medical University, Lucknow.
Very good morning everyone. I am Shreya Verma from King George's Medical University, Lucknow, and I am here to present a paper which is an analysis, the dark side of COVID-19 pandemic and an analysis of elder abuse. So I will be compiling my content in these subheadings. Now, what is elder abuse? A single or repeated inappropriate act that is harmful or distressing done by a near dear of elderly is called elder abuse. And according to the latest WHO report, 1/6 of the elderly experience one or the other kind of elder abuse. Mistreatment of the elderly is a complicated issue. Precise data on elder abuse and neglect are hardly available. A known risk factor is a social isolation. COVID-19 asserted everyone to maintain social distancing to break the chain of transmission and created social isolation among elderly. The limited in-person contact greatly limited the ability for caregivers to provide care in person and limited opportunity for ongoing elder abuse to be detected by others. Now coming to aim. Our aim is to discuss the prevalence and risk factor for elder abuse observed by various studies during the COVID-19 pandemic. So our methodology was that we compile data from year to 2020 to 2022 on elder abuse and was extracted from PubMed and Embase, and the gist of the same is presented after analysis. Search strategy used keywords like elder abuse, risk factor, prevalence, and COVID-19. Now coming to the results. Out of the 7 studies, 4 studies fulfilled the inclusion criteria. Those were original cross-sectional research, hospital and community studies in English language and thus analyzed. The sample size was 13,162, which were taken for community and hospital with age more than 60 years. The overall prevalence overall prevalence of elder abuse was 20.5%. So, as you can see is in pie chart that the financial abuse were, out of those 20%, the financial abuse were 4.12%, physical abuse were 1.78%, psychological abuse was 12.28%, and followed by neglect was 6.74%. The common risk factor was the elderly who have more than 4 children have mental poor health, and the female gender elderly were suffer from depression, and the elderly who have lower income suffer infrequent visits from family members. The protective factors came out to be a stronger sense of community and adherence to physical distancing. Coming to discussion, economic instability, increased occurrence of elder abuse, social distancing, and the shuttering of the non-essential businesses have led to significant personal, social, and economic hardships. At the forefront of these efforts have been measures to prevent transmission of the virus, but also increase the negative consequences of mental health and elder abuse in elderly. A comparative study reported an increase in elder abuse by 83.6% in COVID-19 pandemic. So my conclusion is the identification of risk factor associated with elder abuse is a need of the hour. There is limited data considering overall elder abuse and more scare about during the COVID-19 pandemic. And my limitations were the already underreporting of elder abuse due to stigma, which again increased the COVID-19 pandemic due to limited contact. Study did not use structural instrument and methodological differences. These were my references. Thank you very much.
Shreya, you carefully choose an important topic, interesting topic. I just wondered whether what I understood from the study is data collection was done from the published, it's a form of secondary research basically. Whatever published research is there between 2020 to 2022, you collected those data. But one thing is the elder abuse reports, whatever the studies, they don't refer to a common database. Some of the elderly abuse studies, they collect the data from police reports. Like people report to the police authority and they collect data from those sources. One source is elderly with physical or psychological abuse when they seek for medical help, come to the hospital.
Yes,
from that source you can take.
Yes,
so there are multiple sources and the prevalence rate may vary from source to source.
Yes,
and some people, they collect the elderly abuse data by doing a household survey, going to the household, asking the households. So I just want to know the 7 studies that you included, are they have the common source of collection of the data?
No, sir. Sir, I have collected, sir, from hospital and community elderly.
Hospital and community, that is totally different. The prevalence of elderly abuse in the community is expected to be very high. They will come to the hospital only if they have a significant psychological or physical consequences, तभी वो आएंगे hospital को. So we'll just see the tip of the iceberg in the hospital. But we'll go to the community. A lot of people will have elderly abuse, but they are not coming to the hospital.
Yes, sir.
So the prevalence rate may vary from where you are collecting the data. that is important limitation of such type of studies. So I just want to know how many studies are from the community based, how many are from the hospital based, because you cannot make the total, you cannot club the total sample into one single group because of different sources.
Yes, sir. So basically 3 studies were from hospital and 1 study from were from community.
Okay.
Yes, sir.
Hi, well done, well presented. So, in a continuation of what Sir said, first of all, what is this, what type of study is this?
So this is a descriptive analysis.
Okay. Of?
What's that?
So, when you do a review or an analysis of literature, there is a systematic review and a review. So, is this a systematic review?
So this is not a systematic review. So we are planning to do a systematic review. This is just an analysis.
Right. Okay. You mentioned that the prevalence of abuse. One question. What do you call abuse? How have you defined abuse?
So there are many type of abuse: social abuse, physical abuse, mental abuse, and so.
Because you mentioned in your results the prevalence of abuse was 20%, I believe.
So we included all type of abuses, basically.
So among all the patients or all the participants that were included in the study, 20% had suffered some form of abuse.
Yes,
right?
sir. Yes, sir.
Okay, fine.
Thank you, sir.
This is an important issue that you have raised up because many of us might not be aware about all these things. But what the other panelists are saying, you have a lot of heterogeneity in your data, and you have not studied whether these are from a community or a hospital, as Dr. Chhitij is saying. And third thing is that we have to see which were the factors which were statistically significant, because there can be a lot of confounding factors, or it may not be a statistically significant finding in all studies. So that's why the evidence of systemic review itself compared to RCT is very low, and that also a non-systematic review just gives a glimpse into a problem.
Yes.
So you have cited a glimpse into this problem, but the methodology needs to be much better. But overall, it was a good thought inciting study.
Thank you, sir. No, sir, not yet. Thank you, sir.
Wonderful presentation.
Yes, sir.
I came late, so just 2 comments. Whenever you are presenting some data, it has to be adequately addressed on your PowerPoint, like you presented a pie chart. So whenever you are labeling the portion of pie chart, so it has to be legible, large enough and legible enough so that who are the audiences you are addressing, जो लोग पीछे बैठे हैं, तो उनको वो divisions पता चल जाए, है ना? So very nice presentation. And secondarily, whenever you mention any conclusion of the study, conclusion का मतलब है जो आपने studies देखी, इनका निष्कर्ष क्या निकला, आप क्या message दे रहे हो, that is totally different.
Okay, sir.
मुझे पता चला कि 70% को abuse होता है. This is the conclusion of the study.
Yes, sir.
And to cater that abuse is the advice that you are giving. So there is a difference in these two. So conclusion का मतलब होता है जो आपने जो studies जो भी ले रहे हो, आप merge कर रहे हो, analysis कर रहे हो या single study कर रहे हो, तो उसमें जो data का conclude करके निचोड़ जो निकाला, that must be in conclusion. And whatever you are devising, that can come, but that is not a part of conclusion. Okay?
Okay, sir.
Very well done. Thank you so much.
Thank you, sir.
So with this, we come to the end of the final round of 95% confidence. Meanwhile, we also would like to welcome our judges for the next event, What's Your Double Delta? Dr. Kushagra Gaurav Bhatnagar sir from the Department of General Surgery, Dr. Manjulata Verma ma'am from the Department of Obstetrics and Gynecology, and Dr. Deepak Bhagchandani sir from the Department of General Medicine. I would like to invite our judges on stage to say a few words.
A few comments for the participants. So whenever you present, we as judges or whosoever is listening in the audience also has very little time to process what you're presenting. So try not to give too much information. You have to be very specific and very short in your presentations. The issues that you're looking to highlight them well in your presentations. Because we also have a very small, it takes time for us to register what you're speaking, what you're doing. So we should not be looking to find out stuff. It should be very obvious in your presentation. So one thing perhaps in each of the presentations, the results or the core result may have been a bit more emphasized for all of us. Otherwise, thank you so much.
Yes, and thank you for giving us the opportunity or inviting us for this wonderful session. I totally agree what Harshvardhan said too. The presentation should be, it's an important message that you are conveying to the audience. So make sure that it is properly conveyed. Whatever you are meaning to say it should be clearly conveyed to the audience. So improving the clarity of content of the slides, making it more graphical, and highlighting the important contents that you want to the take-home message that need to be conveyed in very clear, concise manner. That is very important, and you all have taken initiative to present, particularly in academic forum, in a very good, prestigious institute. I wholeheartedly appreciate your efforts. All of you have done well. So there will be some differences between the participants. That will be obviously there, but you all made a good effort. Congratulate. Thank you.
I think it's a very good initiation, and I would like to thank you all, because in amidst of all that joyous activity happening outside and we are discussing such serious research issues, so it itself needs a credit to the organizers. And once again, congratulations to all of you. Thank you.
So very good afternoon to all of you. So it was a very wonderful presentation on topic research, but I would like to one comment to all of you, the residents or students are listening to me. So please come with one participant along with you or one companion with you to attend this event, because the empty hall is not looking good from this side. So I think audience should be more. I think most of the students are interested in research, case presentation, these activities for all of you. Whole team is working hard. So this is my request from my side, and I hope next time you all will be here with more audience. Thank you so much.
It is scary at this level how research savvy these people are. I remembering our times, so we had absolutely no idea about all these things. So congratulations, and track is a great initiative. I'm sure you guys will all be benefiting from that.
I would like to congratulate Shreya Varma for getting 3rd position in the research. Yes.
like to congratulate Shreya Datta for getting second prize in the research 95% confidence.
Winner of today's presentation is Mr. Shubham Tripathi. Congratulations, Shubham.
First of all, I'd like to felicitate Dr. Chaudhary sir from the Department of Cardiology for judging the event.
Next, we would like to felicitate Dr. Ajay Pal sir from the Department of General Surgery.
Next, we'd like to felicitate Dr. Sujit Kumar Kar sir from the Department of Psychiatry. Next, Dr. Harshvardhan sir from the Department of Plastic and Reconstructive Surgery. Next, I'd like to call everyone for a group photo, all the participants and the judges.
Bulletin of KGMU, the inaugural issue, maybe this foundation day. I will request all the participants just to communicate this information to their friends. Whoever is willing to contribute a small article, they can directly send that article or mail that article to me. And the guideline is already available. I have circulated that guideline with many of your friends. So you can directly take that guideline from me. I can mail that guideline to you. So maybe by the middle of October I am expecting articles from you. Thank you so much.
Competition, the final round of it. So we have with us as judges Dr. Deepak Bhagchandani sir from the Department of Medicine, Dr. Kushagra Gaurav sir from Surgery, and Dr. Manjulata Verma ma'am from Obstetrics and Gynecology. We are also waiting for Dr. Geetika ma'am and Dr. Arpita ma'am to join so that we can start it soon. Priyanshi Vyas, Aman Nagar, Gunjan Parashar, Shubham Tripathi boss, Abhishek Kumar. Round. So there will be 4 minutes of presentation followed by 2 minutes of question and answers. So our first participant is Aman Nagar, second year MBBS student, King George's Medical University, Lucknow.
A very good morning to one and all. This is Aman Nagar. I am here to present an interesting case of dyspnea. The patient is a 48-year-old female presented with a complaints of a chronic long history, breathlessness on exertion, and cough with expectorants for last 14 years. And we have the last 15 days histories, generalized swelling and on and off fever. On examination, we find on inspections clubbing grade 2 was present on auscultation of chest, bilateral bronchi and coarse clefts was present. Very good morning to one and all. This is Aman Nagar, and I am here to present an interesting case of dyspnea. The patient is a 48-year-old female presented in a respiratory medicine OPD with breathlessness and cough with expectorants, a very long history of 14 years, and generalized swelling in on and off fevers for the last 15 days as well. On examination, chest examination inspection was done, clubbing grade 2 was present, and on auscultating the chest, bilateral bronchi and core scripts present. On investigation, X-ray of thorax was done, suggestive of bilateral infiltrations with ring shadow. These are all the ring shadows, you can clearly see. On further investigation, HRCT of thorax was done. Moderate to gross tuberous cyst bronchiectasis with surrounding fibrosis are seen in both lung fields. No evidence of pleural field and pericardial effusion. Signet ring sign positive. This is a signet ring. Signet ring sign positive. On further investigation, serum IgE was raised. It's 5812 international unit per milliliter. Absolute eosinophil count was also raised. 31 not. It wasn't raised because of the glucocorticoids we are given to her. And skin prick test report came out to be positive as well. This is the skin prick test for aspergillosis. It came out positive for all three aspergillosis species. On differential diagnosis, we have the three differential diagnoses: COPD, bronchiectasis, allergic bronchopulmonary aspergillosis, ABPA. On diagnosis, we have the ABPA. Further treatment, patient presented with acute breathlessness with respiratory failure type 2. The patient was managed by long-term oxygen therapy with moist oxygen to maintain saturation between 88 to 92% on nasal prolonged for more than 18 hours per day. Treatment including steroids and antifungal therapy was associated with complete resolution of asthma symptoms, allowing treatment withdrawal. The patient was further managed conservatively and discharged after 11 days. On discussion, ABPA is an immune-mediated inflammatory syndrome caused by hypersensitivity to a fungus. It has around 5 stages: acute, remission, exacerbation, glucocorticoid dependent, and end-stage fibrotic. The disease is normally seen in pre-existing asthma or cystic fibrosis. ABPA may mimic tuberculosis. Bacteriological conformation should be sought under most of the conditions before starting anti-tubercular ATT. Here the patient early diagnosed on tuberculosis and was put on irregular ATT for a year. So here the patient was early diagnosis, misdiagnosis 1 year ago on ATT. On discussion, our patient met all the required criteria in the context of his illness. The diagnosis of ABPA seems secure. Criteria established in 2013 by the ISHAM. If total IgE levels are over 1000 international unit per milliliter, eosinophilic count more than 500 cells per liter, positive serum precipitants, Aspergillus fumigatus IgG, serum IgE specific to Aspergillus fumigatus. Most sensitive investigation. This one is the most sensitive investigation. On conclusion, early diagnosis is better and effective in the management of ABPA. Chronic ABPA patient can be presented as acute respiratory failure with carbon dioxide necrosis. Corticosteroids are the main stem therapy for ABPA, although antifungals are also great medication for ABPA who are on steroid dependence. Thank you.
Okay, so this was a wonderful presentation. Can you tell me some other causes of bronchiectasis as well? One that you have mentioned is already ABPA. What are the other causes?
So invasive pulmonary aspergillosis, chronic pulmonary aspergillosis.
Aspergillosis is just one. What are the other causes of bronchiectasis?
Cartagena syndrome.
Upper lung fields, middle lung field bronchiectasis, lower lung field bronchiectasis. Any idea? Okay, fine. One more thing. Kindly go back to your chief complaint slide. Yeah, you have mentioned breathlessness on exacerbation. Can you tell me about the MMRC grading of breathlessness? How do you grade the severity of breathlessness that the patient is suffering from?
Sorry, sir.
Thank you.
Aman, very nice presentation. Great efforts. I would like to ask, could you please tell me other causes, just brief other causes, enumerate them for breathlessness on exertion with cough. One is your differential diagnosis, जिसने बताया जो आपका केस में था IBPA, उसके despite that, what are other causes?
Chronic bronchitis.
Okay.
Asthma.
That comes under COPD, I presume.
Emphysema.
Okay. Your diagnosis is ABPA. Could you just enumerate what findings you will expect to get in classical case of ABPA in respiratory system only? Inspection, palpation, percussion and auscultation. Just 1 to 2 points in each of the parts.
On inspection, so clubbing was present.
I would like to ask in respiratory system examination. Clubbing is a part of general examination. Just tell me, you are examining respiratory system of patient of ABPA. Just 2-3 points in inspection, classical, what you expect to know. Okay?
Okay. So on auscultation, we found out the ronca and creps sounds.
Is there any change that should be present on inspection, palpation, percussion? Patient is breathless.
Yeah, her chest was compromised.
What you expect to see in respiratory system inspection, palpation, percussion?
सर शेप चेंज हो जाता है सर चेस्ट का.
Thank you so much.
Aman, congratulations. Don't be nervous. We know that you are only second year MBBS student, so these questions are going high five to you. So please don't be nervous. Very nice presentation. I will just give you a very practical tip. There are many mistakes, maybe printing error, but that makes, some sort of difficult decision for giving you marks. Like when you were presenting, you wanted to say necrosis, and it was written as narcosis. So these type of mistakes, at least we don't want from your side. And like course, COARCE, you wanted to write it, and you wrote it as COURSE. So these type of mistakes you must avoid. Okay. Otherwise, presentation was good, and don't be nervous. Okay.
I must congratulate you for your presentation. Great efforts. Just an observation when you have written your chief complaints in history. So based on just the historical findings, what other DDs will you keep apart from respiratory? Would you consider any other, if you do not have your investigations in hand, as we normally do in our OPD? So any other differentials you would like to keep apart from?
Please repeat the question.
So apart from the differentials you said, if you do not have the investigations in hand, just history, do you want to keep any other differentials?
Another diagnosis?
Yes.
Invasive bronchopulmonary aspergillosis.
Apart from respiratory system, any other system? I mean, I just wanted to...
Ma'am, core permanent. Core permanent.
Okay, that's another name of COPD only. Any other system, I just wanted to know. I mean, I just wanted to say this message that when you are seeing any patient, you should first hand make differentials in your mind and not be guided by the investigations he has, right? So you should think about other systems. So negative history is conspicuously missing from your presentation. So negative history is a very important part of his presentation, and cardiac is one system you should definitely rule out, right? So that's.
But as all the judges told, there are a lot of mistakes in the spellings and chief complaint also. You have written generalized swelling for last 15 days. What does it mean? What is your understanding regarding this?
Generalized swelling, ma'am.
You have written in your chief complaint. So what is your understanding? Why you have written generalized swelling for last 15 days?
मैम रिकरेंट फीवर ऑन एंड ऑफ फीवर तो इन्फेक्शन हो रहा था तो इसलिए मैम जनरलाइज स्वेलिंग भी
You have written, so just I am asking why you have written generalized swelling for last. What are other differentials for generalized swelling?
Okay.
Why the patient of ABPA develop generalized swelling? Okay, no problem. So read it.